So, hello, my name is Mattias and I am here today to make a presentation at the DBI conference. Uh, Today I will talk about the COVID-19 pandemic and its consequences for people with deafblindness concerning health and services. Uh, As I said, Mattias is my name, and I am a PhD and a psychologist, a clinical psychologist. I'm active as a clinical psychologist at a counseling and support team for people with deafblindness in Stockholm, Sweden. Uh, I'm also working at the Audiological Research Center in Örebro, Sweden, and affiliated to the University of Örebro in Sweden. Part-time, I am active as a consultant at the National Resource Center for People with Deafblindness, located in Lund, in Sweden. To the right in this picture, you see a jigsaw puzzle, which I call the health puzzle, and I will come back to this picture throughout my presentation. Right, today I'm about to talk about many different things, but I will first give a short presentation of my research center and some relevant previous research we've been conducting, and thereafter coming into the health model, the Meekish health model, and after that, the topic of today, which is the COVID-19 pandemic, some preliminary findings, and discussing something or perhaps concluding from where we are at the moment. The Audiological Research Center has been active for many years doing research in the field of deafblindness. We host many active researchers from at least from which two are active in this project I'm going to talk about today. That is the Associate Professor Agneta Andersen Karlsson and Dr. Moa Wahlqvist. We have been active doing research in the deafblind field in our group since 1988, when Klaus Möller started up doing research in Usher syndrome. And we had gained a lot of knowledge about vision abilities, hearing abilities, and genetics in this group. For the last years, we've been more active in learning more about the physical and psychological health of people with deafblindness, and we also have gained a lot of knowledge recently about the family lives of adults with deafblindness, not only from the perspectives of the adults, but from their children and their partners. We have new projects going on in trying to evaluate the life adjustment model as well. And in Örebro, we have a Usher register where we have collected data for many years on people with Usher syndrome. So the picture on this slide shows a treasure chest, and I think the Audiological Research Center for me is really a treasure chest. I will go through Usher syndrome, which for many people in the field of deafblindness is quite well known. It's one of the most common causes of deafblindness among people in adult age. We divide Usher syndrome in 3 clinical subgroups: Usher type 1, 2, and 3. In common, they have this progressive eye disease, retinitis pigmentosa, that gradually restricts the vision field, lead to night blindness, and eventually also a low visual acuity. And people with Usher type 1, they are born profoundly deaf, and in adults they commonly use sign language. The second group, they have a moderate to severe hearing loss using devices like hearing aids, and most often have oral communication. And the least common clinical subgroup is Usher type 3, where you have a progressive hearing loss and along with the visual problems. In Usher type 1 and 3, it's also common with balance problems. And we know that there are many genetic subgroups, so that's the situation of Usher syndrome. And since a lot of the things I'm going to present today is about Usher syndrome, I will not talk much about vision and hearing abilities, but I just want to give this background. In our previous studies, we have learned that people with Usher syndrome, they face a lot of both physical and psychological health problems. My research fellow Moa Wahlqvist has in 2013 presented results from a registered study where we compare the health of people with Usher syndrome to the general population of Sweden, and the figures show that in many aspects, both physical and psychologically, they have more health problems. It can be pain in neck and shoulders and back pain. It's also common to have tinnitus, but perhaps more striking is fatigue, a tiredness that you cannot really rest from. So it's not being sleepy, but it's more like being exhausted, where we have very many people that say that they have this kind of problem. We also have depression, anxiety, sleeping problems, and unfortunately the degree of suicide ideation and suicide attempt is significantly higher in persons with Usher syndrome compared to the general population. However, we can see that not everyone has these health problems, and we also continued our research, doing research about working life, which was my also the topic of my PhD thesis. And we have presented a few studies, and we could see when we made a deeper analysis of the health data that people with Usher syndrome, they did not just not everyone, as I said, had health problems, but we could see that most of the persons having health problems also were outside the labor market. We could see that the ones who work active, they tend to not have the same problems as people who were awarded a disability pension. So in almost every psychological health problem, there were quite low rates among people who were work active compared to the ones who were retired. And you cannot see any age differences or any differences in vision or hearing between these two groups. This was very interesting, so we, instead of just making quantitative studies and register studies, we wanted to make a qualitative study to learn more about what is it that seems to be protective in working life. So what we could see after making interviews of 7 persons with Usher's syndrome type 2 being work active. Uh, uh, we, uh, we, we could see that they were really striving to finding a work balance. They we could see in our study that people who were work active, regardless of vision and hearing problems, had a place where they could fulfill very important psychological needs in their working life. They all had a sense of satisfaction. They could have a lot of relations at work, and they could have use of their competence. However, they were also facing a lot of daily insecurity and limitations and exhaustion that they had to face in everyday life. Yet, with these experiences, they had also developed many skills how to handle these situations in order to gain this balance. They also are very used to handling an uncertain future. And I think I'll come back to that later on in the presentation when I get into the COVID study. And in this picture, it's myself trying to making a balance act in a kayak. One of the studies we also made was also focusing not poor health, but rather how can people with Usher syndrome stay healthy? What kind of strategies do they use to handle a very challenging life situation? Uh, uh, in the study that we presented in 2019 and that has been very much cited, I'm happy to say, we made interviews of people with Usher syndrome type 2, how they handled their life situation. And we could see that they really had a lot of strategies how to prevent, but also to resolve problems in life. So they had very much practical ways to handle things, and they also had a lot of emotionally focused uh, uh, or ways to comfort oneself in times where they faced difficulties. Uh, you could see that depending on age, or perhaps more likely depending on the progression of vision loss, the strategies they used were different, um, and that is interesting because they the older they were, they had sort of developed different kind of strategies. Uh, However, I will focus a few of them because I'll come back to them in the present study or the study of today. That remaining active, as was also seen in the studies of working life, seems to be very much of importance. But not only to be work active, but also leisure time, spending times with friends, or uh, so it could be playing the piano just as well as going to work. But remaining active seems to be very important. Using devices that could be accessibility devices, but also tablets and smartphones, which give a lot of support. But it could just as well be the hearing aid or the white cane. That was a way of that facilitated their lives. The use of support was, of course, also important, and that could be informal support by friends, by family, or partners, but it could be just as well more formalized support, which is accessible in many, I'd say, high-income countries, as interpreters, sign language interpreters. It could be, or it could be also having the ability to have a guide to be able to be more active. They had also ways to appreciate the present and that was in a situation with a challenging and uncertain future, a very important strategy to really seize the moment and not think too much about the future. What we could see as a sort of overarching theme in this study was that people tried and strived towards being at the helm. And I have a picture of myself sitting in the boat. I have a visual impairment myself, and I'm the one keeping my hand on the rudder, deciding what way we are going. But due to my limited vision, I have someone in front of me navigating and can give me advice where to go when out at sea. Okay, we can see that our previous studies, and I want to conclude that trying to understand what we see, you can have use of a health model. And the Meekish health model tried to sort of divide health into different parts and making sure that health is not just not the absence of disease or it's something bigger than that and includes more pieces. And I have made a jigsaw puzzle with different pieces. And we can see that people with Usher syndrome, they have a biologically given potential, which is one piece of the puzzle, with a poor hearing ability and a poor vision ability. And the medical condition often makes their vision lower throughout time, but they also seem to have, as I just presented, strategies, life strategies that they can use how to handle this challenge. And by using the life strategies, you can say that you have a personally acquired potential. So if you have a visual impairment but know how to use the white cane, for instance, then you have a strategy to navigate though your vision abilities are quite low, and that can buffer a lot for the difficulties of not being able to see so good. We can also see that what we call the social determinants, which is one green piece of the puzzle here, that could include to get education, access to healthcare, the welfare system, schooling, the labor market, for instance, or subsidized employments or so. It could also be access to guides, to interpreter services, and so on. That is of importance also to buffer for the vision and hearing loss, and for everyone in society to have education. We know that's important, but in this group it has also to be an accessible education, for instance. But to be helpful, we also need demands of life. We need a work, we need a working life, and the life demands, they tend to shift throughout life, and so does the other pieces of the puzzle. But working life in many people with Usher syndrome is of importance, but as I said, it's important to have a balanced working life. So the red piece of the puzzle, which is the life demand or working life in my example, if the piece is too big or too small, then it will not fit into the puzzle. So it seems to having a balance is very much of importance. And this health model, the Meekish health model, I think it can be very helpful to conceptualize differences, and also when we come to COVID-19, which is really a shift in the life demand, I'd say, that can also affect many pieces of the puzzle. And what Meekish models say is that health is a state of well-being, and it is dependent on many different aspects. So it's not just the biologically given, it's also the personally acquired, and the social determinants. And when you have a situation where all these pieces of the jigsaw puzzle are sort of in balance with each other, then a person would perceive a good health. So that was an introduction to our previous studies, and now I'll get over to what I'm going to talk about today, which is the COVID-19 pandemic. And this picture was for many of us, or perhaps all of us, I'd say, a very unwelcome guest that suddenly showed up in springtime 2020. The COVID-19 virus, uh, I do not have to say much about it, but it affected everyone in society throughout the world, and so also in Sweden. And I'll just, if you are watching this film, you can pause it for a while and you can perhaps consider what your own experience is of deaf blindness in relation to COVID-19. I think that every one of us working in the field or who have deaf blindness themselves have experiences. Okay, well, uh, if in jigsaw puzzle terms, in the Meekish health model terms, you can regard the COVID-19 pandemic as a new life demands for people with deaf blindness or people with Usher syndrome in particular. Uh, we had a situation where the societies shut down. Face masks were mandatory in many countries, and you should be stay at a distance from people. Many things in society changed as starting up for in healthcare services doing uh, uh, remote healthcare and instead of physical meetings. Uh, okay, my clinical experience from working at the counseling and support team in region Stockholm in Sweden, we could see that many of the areas that normally is a challenge for people with deaf blindness, communication, information, orientation, and mobility, they seem to be very much affected. We could see that people with Usher syndrome faced really big difficulties. You needed to be close to other people to be able to talk to them or to hear what they say. And if you're a sign language user or lip reader, communicating with face masks was really a challenge. It was also a challenge to get access to information. The flow of information was very, very big, and it was difficult to sort out what info is of importance to me. For those who used sign language interpreters to access information, many of the information channels were not uh, accessible in sign language. So if you couldn't understand spoken Swedish, you couldn't get any such information from television or so. Uh, to move around freely, many use friends, family, or formalized support as guides. Uh, Going to healthcare services was also a challenge because taxi services closed down and also people were told not really to go out. And if you need someone to guide you, you have also to be close. So we could see that in many different aspects, people were really uh, affected by the pandemic more than perhaps other people in the population. And deaf blindness and being keeping distance to others is really a paradox, I'd say. But these clinical observations, we really also faced a challenge in my clinic, and I wanted to make a research project out of this, as I'm a researcher, and my colleagues and I, we designed a study, and we were very fortunate. So we received funding from one of the big actors in Sweden giving grants to research in disability field. And we decided to make 3 different studies, one towards people with Usher syndrome, one towards people who were studying in high school or university, and a third study where we made a study on people, professionals working in the field of deafblindness. And why do we want to do this? We wanted to do this because we understood quite quickly that this is a shift, very quick shift of how to work in the field of giving support to people with deafblindness. And at the moment we decided that we decided to make a proposal for grants. It was really in the middle of the pandemic, and we didn't know for how long it would last, and we also didn't know much about what of the sort of changes in way of giving support would last after the pandemic and what would not. But we wanted to create a basis for to develop new services and to make more accessible health services to people with deafblindness. That is of importance. And we wanted to learn more about the health of the persons with deafblindness and how the pandemic has affected their daily life. So the first study I talked about was that we wanted to reach out to people with Usher syndrome, and reaching out to people with Usher syndrome with you can do it many ways. We decided to make instead of sending out a questionnaire, we decided instead to make interviews. We thought that would be a way to gain personal information and to learn really much about their experience of handling the COVID-19 pandemic. So we decided to interview 20 persons, not just with Usher syndrome type 2, but with Usher syndrome type 1 and 2 and 3. So we invited people from all over Sweden, and here we have a picture of Sweden. We made some of the interviews by using video systems, and some of the interviews were made instead using face-to-face interaction. So it's been a lot of traveling and also a lot of digital interviews with many adjustments. And we want to make an analysis with content analysis. One group that we know from the clinical experience had really tough, especially in the beginning of the pandemic in Sweden, when all schools shut down. So what happened was that all students needed to have remote education, and that was, of course, a challenge for a young person. So we have reached out at the moment to 4 persons with deafblindness, not just Usher syndrome, but the different kind of deafblindness. And then we have made interviews, and we will eventually make an analysis with an interpretative phenomenological analysis. The third study was on professionals working in the field of deafblindness, and that were giving habilitation services. There are such teams throughout Sweden, 21 of them, and we wanted to make focus groups interviews. The focus groups interviews were conducted both digitally and on site. So altogether, we have interviewed 20 persons in 6 different groups, and we want to make a content analysis of their interviews as well. So all the 3 studies are qualitative, and we are now just starting up doing the analysis of the last of these studies, the one on professionals, and we will thereafter continue making analysis of the other 2 studies. So all data collection is finished by now, and the project is now in a phase of analyzing data. So perhaps we're coming to the most interesting part of this presentation, which is concerning our very preliminary findings. And I'd say this is a very preliminary finding, and it's also something I present here at the conference, but I'm very keen that the information will not be spread or published elsewhere. So because there are still interviews to be analyzed, and we cannot really make any conclusions, but these are some highlights. And this is really from the perspectives of professionals. It can be social workers, psychologists, it can be people who are low vision teachers or special teachers in hearing or communication. So it's been really a range, and it's also been professionals from all parts of Sweden, both more like urban parts and more like remote parts. There are also experiences from people who are mainly active giving support to people with congenital deafblindness, and others who are more into giving support to people with acquired deafblindness. So first of all, they really thought that we do not have any knowledge at all, not of the pandemic or how to give support during a pandemic. There is no manual. We normally know what to do and what services to provide, but there was a shift, a rapid shift. So you were really left to make decisions on your own. They were also very anxious of the risk of infecting others, infecting their patients, and especially the risk groups, of course. One thing that also was very apparent from the start was that everything had to really change from physical meetings, which was the most common, to instead giving different kind of digital platforms. That could be a video system care, or that could be some kind of using telephone, email, or ordinary mail. One thing that one person did was teaching Braille using just mail service. So they have like a mail course in Braille, sending out different kind of topics and some homework for and some assignments and then the person with deafblindness sent back things in Braille to the teacher. That could be one thing. Others could be having a video meeting with a psychotherapist from from the home, and sometimes with an interpreter access to an interpreter at the home, but the psychologist being remote. So, and telephone, of course. Uh, you could see that there were really differences between the groups. Some patients, they had quite good access to digital platforms before the pandemics. They were the ones who were also gaining most of the digital services, while others, they, especially elderly people and people with perhaps more intellectual problems, or who were not really digital into the digital field or didn't have the digital tools. They didn't have the devices needed, or they didn't have the skills to sort of shift from a physical meeting or to a digital. The professionals, they really try to make every effort to give support, but they also faced a lot of ethical stress because they could not, they knew that there were many things to do, many persons to teach and to support and to give services in many ways. And they could see that some people really suffered from not gaining what they needed. And that led to a very stressful situation of the professionals. Some places, schools, especially specialized schools, but also regular schools, were not accessible. They were shut down, or they were closed to foreigners or healthcare services, so they couldn't come there. And the same was the situation for housing of the elderly, which was also closed down for everyone outside, in order, of course, to prevent spread of the disease, but also giving no service at all to some groups. And some groups faced a lot of, you could almost say, for a while, a total isolation, especially before the vaccine arrived. And that was, of course, elderly people, but some people with congenital deafblindness, especially adults living in specialized housing, they were in many ways very isolated. And so it was with uh, some families as well, especially if they had children with the risk of getting infected or getting very ill after being infected. They also withdraw, and some didn't see anyone outside their family for many years, for 1 or 2 years. And some elderly people, they could see that even after the pandemic, they have sort of got even older, and they really uh, do not feel very well after the pandemic, and they also lost cognitive skills. Uh, uh, and you can also see some positive things, some change over time, some digital platforms that was in the beginning perhaps absent or not accessible at all, not for the professionals, or and even less accessible for the people with deafblindness. Screen readers were not adjusted to the platforms, the video platforms, or they were regarded not being safe enough doing healthcare services on, due to regulations and GDPR, which is common in the European Union, that you cannot use any system. But it could also be that you haven't really learned how to use them, and after some while, they both patients and the caregivers could really learn a lot, and they have learned a lot throughout the years, how to use the systems and how to sort of make things more accessible. And screen readers and so has also developed through the years. And this has led to that the professionals now feel more competent and has gained self-confidence. And also some kind of confidence that throughout the years they have really changed their way of working, and this they know that they could do that, and if there would be a new pandemic, they can do it again. However, there are a few groups, and especially vulnerable groups within the deafblind group. Some people have been away for such a long time and has been avoiding physical contact, and also has been very isolated for a long time, and they suffer from psychological distress. Uh, and this is going on also long after the restriction was gone. So some people still suffer. But altogether, professionals feel that they have learned a lot from each other's and patients. Uh, for the future, you can see that there is a lack of tailored or digital platforms, that the digital platforms are not accessible for everyone. There are groups that are really outside or excluded from digital care and digital platforms. And this is a challenge now when the society is shifting towards giving more that kind of services to many groups in society, not just people with deaf blindness. But after the pandemic, having developed systems, you tend to use them more frequently now than before the pandemic. And there are groups out that are perhaps even more outside or more excluded. And some persons with deaf blindness are indeed a part of that group. So, how can we use these preliminary findings? I think that there is really too early for us to say, but one thing I think is of importance to learn is that the leadership uh, and to have a good team, if you're a professional, that is of importance. To have someone who can help you keeping the hand on the helm, and also having colleagues to chat with when you have a situation that is new for everyone, that is very supportive, and also access to supervision, though it might be also remote. There are risks with the digitalization for the future, and we can see that many people are excluded, but some, especially the ones who have the ability to use them, for them it can be also an opportunity. You don't have to travel so much, which is very exhausting for many people, and there are in many ways, it makes things easier. You can just go for seeing your social worker for a short meeting, and you don't have to travel all day. Uh, uh, I think that professionals in deaf blindness, they are very good at sort of tailor making all their services, and the pandemic has perhaps really put focus that you have to be able to adjust and to change and to shift and really make something thinking about this specific individual. And professionals in the field of deafblindness, they are very good at doing that. And this kind of skills, not sort of getting panicked when things go differently, that is something that we could see in some people in the field of deafblindness, that they are quite confident that they can handle shifts in situations. And so is also the situation among some of the people with deaf blindness, perhaps. That we don't know yet because we haven't analyzed. Uh, but from the perspective of the professionals, we can see that it had been important, as we could see in previous studies, to remain active, not just to remain active as a person with deaf blindness, but also to keep up activity in the healthcare services. And the worst is for the person that you couldn't reach out to. So it's better to do something than not doing anything at all, someone said. Uh, And it was very important also to try to give hope to people. You couldn't perhaps give them what they needed, but you had to sort of give them something so they could sort of stay there for a longer time, and sort of buffer for the anxiety they had, and just to keep some kind of contact was of importance. Uh, we can see that there is also a need, an urgent need for teachers giving sort of learning people not just to use their screen readers, but also to learn how to use Zoom and Teams and that kind of things, platforms, digital platforms that gets more and more common. So this was about as much as I got today. I want to thank all of you for listening today. I want to thank my colleagues, Agneta Andersen Karlsson and Moa Wahlqvist, for helping me out with doing all this research. Uh, I especially want to thank the participants that have shared a lot of very nice and interesting experience, and spent a lot of time taking part of our interviews. Um, and also our funders, Forte, who made it possible for us to make this kind of uh, study. So by that, I will close down this session and